Hey everyone, it's Friday. That means it's time for our weekly compilation video. This week we've been talking about hormonal vestibulitis, kind of specific things with that in terms of, diagnosis, treatment, looking at how it affects other conditions and so forth. Couple of housekeeping things. First of all, the languages of the week were Manx, which is from the Isle of Man, which I think has one of the coolest flags out there, Korean, and then yesterday we did the Republic of Georgia, so Georgian. If you like that, let me know. If you think it's kind of silly, well, that's too bad because I like doing it. Otherwise, thank you so much for those of you that, responded to the question about what Haven means to you. That will play a big role in our big, reveal on Monday. So anyway, let's get started. So remember just kind of a brief overview of what the vestibule is from an anatomic standpoint. The vestibule is one of the specific parts of the external genitalia. And basically, if you kind of imagine the vulva kind of looking like this, where you have the labia majora on the outside there, you've got your clitoris up top, you've got your perineal tissue down here. The labia minora kind of come a little bit on the inside of the labia majora there. They go up towards the actual hood of the clitoris. And then about halfway down the labia minora, what you'll see is a kind of a line of different type of texture. And this is called Hart's line. And this represents the distal border of the vestibule. If you follow that into the area where the hymenal remnant is, or in patients who still have an intact hymen, the hymenal ring, that is the proximal border of the vestibule, and so that tissue itself is considered the vestibule, that link there. And this extends more, anterior or upwards towards the urethra and the periurethral glands, or what are called Skene's glands, and then also down towards the bottom, which is kind of, if you imagine a clock face like at 6 o'clock position, that's called the posterior fourchette. So remember that from an anatomic standpoint, the vestibule is an embryologic homologue to the portion of the urethra that comes out of the prostate. That means that the vestibule is not only rich in estrogen receptors, but also in androgen receptors. And so when you remove those hormones from the vestibular tissue, what you'll typically see is irritation, redness, discomfort. Some patients report like a stinging sensation. For others, it's a burning. For other people, it's raw. Pain is very subjective, so there's a lot of different adjectives we can use to describe that, but everyone can kind of agree that it doesn't feel the best. The other thing to kind of consider is with vestibular irritation, especially if you're getting irritation in the Skene's glands or the periurethral glands, what you'll find is that those symptoms will mimic urinary tract infection symptoms, because you'll have almost like a urethritis. So patients who have chronic UTIs, yet when they go in and they give a urine sample, they never find any bacteria, you always want to look to see if vestibulitis is potentially a culprit for that, and kind of treat that accordingly. So, obviously in looking at this, the big question is, okay, well, so what can go in, what can cause these type of symptoms? So bar none, the, most common cause of hormonal vestibulitis, especially in reproductive age patients, is the use of oral contraceptive pills. Now, a combined oral contraceptive pill typically has an estrogen in it, and then a progestin, or a synthetic progesterone. The estrogens, certain ones, specifically ethinyl estradiol, will cause an elevation in sex hormone binding globulin, or SHBG. SHBG's main role is to go around and pick up kind of unbound sex hormones, and it preferentially chooses androgens, like testosterone. So if your SHBG is really elevated, what you'll see then is a reduction in circulating testosterone levels, which obviously is great for things like for patients that have really bad acne, hormonal acne, oily skin, things. But in terms of the vestibule, that reduction in testosterone can lead to vestibular symptoms. And this is something certain estrogens don't have. The other thing that we see is that typically you can avoid that elevation with a transdermal application of this medication. So if you're using a hormone patch or a NuvaRing or things like that, you may still have some effect, but typically it's not as high as the oral one. The second thing is to look at the specific type of progestin. Now, progestins come in different varieties. They're either kind of anti-androgenic, meaning they're going to block testosterone. A very few of them are kind of more pro-androgenic. But really they, especially nowadays, we're seeing more kind of anti-androgenic progestins. The most common one, or the biggest culprit, is drospirenone. And this was combined in a hormonal contraceptive pill called Yaz. And Yaz's kind of big claim to fame was that it was really, really good in reducing acne and kind of those elevated testosterone things. And it does that very well. But obviously, combine that with some ethinyl estradiol, and you've got really, really, really low testosterone levels, and that can play into that hormonal vestibulitis. So for patients who are on OCPs that complain of those symptoms, the very first thing to do is to take them off the OCP. And then you're going to want to do some kind of replacement therapy, and I'll talk about that in a second. So moving outside of OCPs, we get into kind of our second category of hormonal vestibulitis that we typically see in kind of a non-pathologic state, and that would be periods of very low estrogen. The most common is going to be menopause. But kind of following close behind that is going to be patients who are postpartum, especially breastfeeding patients. Now, what's going on there is, depending on kind of the mechanism, either kind of ovarian reduction of hormone production with menopause, or suppression of hormone production secondary to elevated prolactin levels in nursing patients, you can see this same type of response. Now remember, with pregnancy especially, hormone levels go way up. Estrogen levels go up, progesterone levels go up, testosterone goes up, they all go up. And so after you deliver, those hormone levels go down, and that can cause a lot of the irritation and rawness that we see with kind of those postpartum, vulvovaginal changes. Nursing patients, prolactin can act as an inhibitor of estrogen. So high levels of prolactin antagonizes the production of estrogen, and so those estrogenic levels are lower even more. And so you can in turn have that, vestibular kind of downstream effect. Now with postmenopausal patients, I talked about this with genitourinary syndrome and menopause, but this is really kind of the big culprit with that too. And so, once again, the ovaries are the main producers of gonadal sex, or of sex hormones in the body, or the gonads are ovaries and testicles. And the ovaries specifically produce 4 to 10 times more testosterone than they do, estradiol on a daily basis. So, you got to think about both of these things. And if you're just giving patients estrogen for, post-menopausal vaginal changes, you may be missing some of the picture. And they, if you included testosterone in there, they may notice even more improvement. And this gets into kind of my key, or my main medication for treating hormonal vestibulitis, and you probably can guess it. That would be Intrarosa. Intrarosa is an intravaginal DHEA, or prasterone. DHEA is a prohormone. Remember, it breaks down into both testosterone and typically estrone, which is a type of estrogen. Oral DHEA, you're bazookaing things. You don't know what you're going to get. When it's given vaginally, it has more of what's called an intracrine type of breakdown, which means that the hormones that tissue needs are more what it gets. So if tissue needs more estrogen, you get more estrogen. If it needs more androgen, you get more androgen, and so on and so forth. So can postpartum moms get Intrarosa? Yes, it's off-label, but you can use it. Can people who have been on birth control pills that you take off it, can they have Intrarosa? Yes. Once again, off-label, but you can use it. So there you go. Obviously, you can do, if that's too expensive for you, you can compound the DHEA into an intravaginal capsule. You're going to use around 10 milligrams of that prasterone there, and you're going to insert that every night before bed. So that's kind of the way we deal with that. Now, kind of moving one step into other conditions that really will affect this, in patients who are battling breast cancer, or who have, already combated breast cancer. One of the main things we see is the use of, especially in patients that had estrogen receptor positive breast cancers, patients who develop a aromatase inhibitor related hormonal vestibulitis. Aromatase inhibitors are a class of medication. Letrozole is probably the most well-known one there. And aromatase is an enzyme that converts testosterone into estrogen. Specifically estradiol. And so the thought is that if we are blocking that conversion, the estrogen receptor positive breast cancers are then going to kind of starve and go away. Well, obviously that's blocking that everywhere. And so you can get this vestibulitis from that too. And so, in replacing those hormones vaginally. The latest recommendations from the North American Menopause Society said this can be done, but it should be done in conjunction with a patient's oncologist. Once again, this is where DHEA can really play a role in things, especially intrarosa. But still, you're going to want to talk to your oncologist about that. But that's another area that we definitely see the hormonal vestibulitis. Now, I know that I have a lot of people that have different lichenoid dermatoses that kind of follow my channel, specifically lichen sclerosis. And so a question I get a lot of times is, how does this affect whatever I'm talking about, affect LS? Well, so you can definitely have a vestibulitis with LS. Now, remember that lichen sclerosis really doesn't go in super far into the vagina. And that's the difference from lichen planus, which you can get vaginal involvement. So yes, you can get some vestibular kind of spread of the LS, but typically it's more of a vulvar disease. That said, if you look statistics, who gets LS? Well, typically patients with low estrogen levels. So that's why you see a higher rate in patients who are postmenopausal and a higher rate in patients who have not gone through puberty yet. Now, once again, anyone can get it. It's not just those people, but statistically speaking, those are, if you look at the research studies, which albeit have not been updated, so there's another caveat, are who you're going to see. I will give you this response to that, however, and that's that patient population is actually the one we worry more about in developing squamous cell carcinoma or skin cancer from the lichen sclerosis. So even though, yes, premenopausal patients can get it, and yes, those patients can get the squamous cell changes there, you worry more about it in the postmenopausal patients. And so that's my 2 cents. Obviously, check your vulva. If you have LS, get it checked out. Don't discount it just because you'll say, well, I'm not in menopause yet. But anyway, so back to the vestibulitis. So obviously, if you're in a low hormone state, what can then arise? The hormonal vestibulitis. And so can you use medications for, I'm just going to call it HV from now on, HV to treat LS? Kind of, in that the HV meds may help the HV, and therefore it may make the symptoms of the LS better, but it's not actually treating the LS. And so that's why you want to use your steroids, because the steroids are the only thing that have been shown to reduce the formation of the squamous cell cancers. So obviously there are other treatments for LS too. We can talk about those in a future video. Lichen planus is a little bit different, because remember, lichen planus does get that vaginal involvement. And so you're going to see a lot more benefit, I will say, with hormonal medications and treating LP versus LS with HV. There's too many acronyms, too many initials. So use your hormones in conjunction with your steroids for lichen planus 100%. You may not need them with lichen sclerosis. That's kind of the too long didn't read type, condensation there of that. Other types of things we see, other autoimmune diseases, just in general, pretty much anything that causes a reduction in hormone production or blocks the effect of those hormones can lead to a hormonal vestibulitis. So head injuries, if you have what's called hypogonadotropic hypogonadism, secondary to pituitary trauma or a pituitary tumor or things like that. What that means is that the gonadotropins, or follicle stimulating hormone, luteinizing hormone, their production is going to be low. Therefore, the gonads are not going to get stimulated. So the gonadal hormones are going to be low, your estradiol, progesterone, testosterone, which then downstream affects into the hormonal vestibulitis. So the gist of all this, and the amazing thing, I think, is that the body is all interconnected. You can diagnose a brain tumor from symptoms that are occurring in the vulva. Now, think about that, or in the vestibule. Think about that. That's pretty cool. If you know what's going on, you can backtrack your way back up to the brain and say, here's the actual issue. So, really, that's kind of the take-home point of this whole thing, is that if something is blocking hormone production, or it's keeping the hormones from getting to the target tissue. I'm looking at you, ethanyl estradiol. Then you're going to have, those issues. Also want to talk with that spironolactone. That's another one. Spironolactone or aldactone is a common medication we see that's given for, like acne, oily skin. Aldactone or spironolactone is originally it's a water pill. It's a diuretic. But it decreases the production of those sex hormones in the adrenal gland, or kind of changes them a little bit there, if you will. And so you can see a reduction in testosterone. So patients who go to their dermatologist and they say, I have really bad acne, and they get put on the aldactone. They say, my acne is great, but now it hurts to have sex. Yep, there you go. So always kind of look at that too. So anyway, that's kind of the video today. Obviously, if you have questions, please let me know. Put them in the comments below there. Like I said, next week we'll kind of be switching gears a little bit. And otherwise, I hope you have a wonderful weekend. I'll talk to you then.